With that, we're going to swing over and move to our next session, which is called If Obesity is a Disease, Why Can't I Get Help? This one is going to be a really good one. And joining us is Dr. Tasneem Sajwani. She's a fantastic example of that next generation of healthcare professionals who really get it and are working hard to make positive change. So, there she is. Hey, Taz, how are you? I'm
Hi.
I'm still just a girl in front of a camera talking to humans that I adore all day. So everybody indulge me as I see faces of humans that I absolutely adore. So Dr. Sajwani is the medical director of the Edmonton Weight Management Center and Family Practice. She completed her family medicine training program at the University of Alberta in 2008 and earned her fellowship with the College of Family Physicians in 2019. Additionally, she is a diplomat of the American Board of Obesity Medicine. That is a big deal, you guys. Being ABOM is a big deal. She's also someone who is an ally and a champion for change. She is committed to challenging obesity bias and stigma through her practice and through her advocacy. So welcome, Taz. Yay! Thank you for being here, my friend.
Hi.
So good to see
I'm
you.
I'm so excited to be here. And I was just following Tara's conversation, and she's inspiring. It just pumped me up. Honestly, I was clapping in my little corner here.
That's awesome. She blows me away. From the minute I met her, I've been like, that's my people right there. So before we tuck into our conversation today, though, I would love if you would just take a couple minutes, introduce yourself, and maybe let everybody know what brought you to your work in obesity management as well. We'll start there at the very beginning.
Yeah, I mean, I've been a family doc for it's coming to 2 decades now, about 18 years. But I'm going to say that it was something more personal that brought me to obesity medicine. I've struggled with obesity again since a very young age. When I was younger, my pediatrician had told my parents that I needed to cut the cheese in my diet because I was too overweight. So this is something that I've heard since I was a very, very young girl and kind of internalized and thought it was no big deal, just like everyone else, until I was having troubles getting pregnant. So it became really real about 7 or 8 years ago. And then I was hearing conversations amongst my colleagues in regards to the science around weight, and that was incredibly interesting and eye-opening for me. And I just went down that rabbit hole, and I never came out.
Oh, there I am. I was like, where am I? I'm talking, but I'm unsure.
I
Okay,
lost you
awesome.
too.
That's all good. All good. This is going to be just a day of people talking to each other. I love that. I love that you have a personal connection, but also that you have framed your practice around kind of making this better for everybody. And as you said, you're kind of that primary caregiver or that family doc, which means you're probably often, and you work in an environment where you're often that first point of contact for people who are interested or finally worked up that courage to talk about their obesity or obesity in general. So that's one factor. We also know that from a scientific lens, that our understanding of obesity has had some really significant breakthroughs over the last few years. But in some ways, they've kind of almost taken a backseat to those latter conversations about obesity medications in pop culture right now. And I can imagine that adds a lot of complexity to the conversations that you're having to have today. And I think maybe that would be an interesting place to start as well, and to hear from someone who works in this space and has training in this space a little bit about what obesity management is looking like in your practice today, how you approach those topics, and kind of what you're seeing out there.
So when it comes to the pop culture, it's open conversation. Sometimes I bring those things up myself because if we are
Yes.
in a conversation where we're talking about the different options or modalities we have around managing weight, pharmacotherapy comes up, exercise comes up, nutritional changes come up, and traditionally these come out as, oh, this diet here, or this exercise plan here, oh, this medication is going to, end the world. And just having those conversations up front and talking about the actual evidence behind them, and having that clear conversation. And most patients that do come in and have these questions leave with so much more information and so much more empowerment, so that not only can they explain that to themselves and their close family, but if anyone challenges them on that, they have answers.
That's such a big one, right? We know this is such a sensitive topic for people, and there's a lot of bias and stigma attached to it. I know for myself, I avoided bringing up the topic probably in healthcare more than I wanted to talk about it. And then when I did want to talk about it, it didn't go well. So then that went right back into the bucket that we pushed down. Um, I'm wondering if you're still getting that sense that people are still hesitant. Sounds like they are. And what do you do to kind of bring that out? Is it just really putting all of that information right on a table in a way on the table in a way that people can approach it? Is that the biggest win that you've seen?
It's asking. It's asking if it's
Ooh,
okay. Is it okay if we can chat about this? Is this something that you would want to chat about? And letting my patients lead that discussion, answering questions honestly. And when there are questions, answering them with evidence and not just the old, hey, just if you just ate a little less or worked out a little bit more, those aren't real. They don't work.
yeah, they really aren't. And that's so true. And I think many of us probably walk into the doctor's office a little feisty and or with a lot of that misinformation that this is really just about forks and feet, what I put in my mouth and how I move my body. And I know when I finally got to the right kind of care as well, and it became not about that. And in fact, they were like, maybe take off one of your three step counters and like biometric devices that you're
Yeah.
wearing, that I was like, but then how am I going to know what I've achieved or earned in some ways? So maybe
Yeah.
let's switch and talk a little bit about that chronic disease state of obesity and why it
Yeah.
isn't about forks and feet. Maybe you can let's go there, and if you can help us
Yeah.
understand a little bit
Let's
more.
go to the ABCs.
Yay.
So, obesity is, in its essence, a neurobiological disease. It's not, in essence, a disease of choice. I'm not saying that chronic disease like obesity isn't influenced by external things. Sure, there's an influence of genetics, there's an influence of the medications we take, of the trauma we've had, physical or emotional, nutritional quality, or even access or sleep. There are so many different factors that can influence chronic disease, but influence any chronic disease, not just weight. But in its essence, it's really a connection between the gut and the brain and the peripheral cells. And sometimes there's abnormalities in the receptors in the brain, in the hormones in the gut, and the incretins in the gut, and the cells in the periphery. Things mess up in every chronic disease. And obesity is very similar to all of that. It is actually that. So, and it doesn't just go away. We can't just treat this. A chronic disease means it gets better, but it comes back. And so we continuously need to manage things like that.
Mm,
So, in and of its essence, it's not something that we choose.
absolutely. And that's a really important starting place, I think, for a lot of people. I know for myself it really was as well. And there's also a factor I know was true for me, and I don't mean to talk about myself, but it's just my best frame of reference, where it was also like I really did believe all of those magazine covers. I believed the years of doctors telling me that I need to eat less, move more, or that it was simply by my doing. So being told the opposite, I was also I and navigating life meant I became really hyper compliant, and I was like that A plus student, and I was going to do everything I could to be compliant everywhere else because I couldn't in this one zone. And then having to switch that narrative in my head, that was also wasn't easy though, because that kind of meant I was wrong again on some level. Have you experienced that, or how do you help your patients with that mental health or that like brain conversation for their own sake and their own grace that they can give themselves?
Well, I think it's kind of the stages of acceptance of what we can
Mm,
control and what we can't. What obesity has been like disguised as this disease of choice for way too long.
yes.
Not only for um, people who don't struggle with weight, but even for people who do. Um, and now to say that, hey, wait, there's a biology to this, there's a pathophysiology to this. I think switching that narrative, yes, in one way can be, what do you mean I don't control this? What do you mean I can't change this just by willing it or being the best student or the best eater or the best exerciser? Why, what do you mean I can't do that? But then also understanding that there is a reason that this is difficult. This is not
Mm,
because you're not good enough.
mm. Louder for the people in the back. Yes. This is not a burden that we need to carry all on our own. And we need to give ourselves that grace. I'm just going to keep saying that today because it really does make all the difference in how you're able to show up for all of those other pieces along the way and how receptive that we're going to be to that new information or that additional information that might be coming to us. So let's talk for a minute, kind of about the healthcare community itself, the communities of practice that are out there. So many people on the call today or in the sessions today might be aware that we released guidelines on obesity care for Canada, and those were released 4 years ago. But we know again that general population is talking about obesity, obesity medications louder and more frequently. How have you seen those two things kind of come together in with your peers and your colleagues? I know you had said before you'd heard people talking and you went down a rabbit hole, and that sounds like those were good conversations, people really interested in understanding obesity for all the right reasons. But we know that there's a world of community out there as well that still is holding on to old beliefs. What's your lens or your take on that moment from a healthcare professional sensibility?
So prior to me even hearing those conversations, I would say I had no idea either.
Mm,
Right? So you need someone to bring that to you, or you need to try to find a different reason for it. There may be a personal reason of a healthcare professional might do that, or something that's just right in their face. I have to say that it has changed in the 5 years that I've been practicing obesity medicine. The questions are much more insightful. In fact, there are questions. There never used to be questions. Hey, the guidelines are here. I see that, we need to do this kind of counseling, and these are the recommendations to make, and these are the medications that we potentially use. And I get questions about that. And sometimes it's even, I know this is going to take time and I don't have that time to fit into my clinic. Is it okay if I refer here or refer there? Or how do you get access to care? So I'm actually quite hopeful because it's after the guidelines came out, it's so much more in the face that it's hard to ignore that there is a science behind this and there is a way forward for our patients that isn't as archaic as it used to be.
It's it's very, very true. And it almost, you're right, it almost sticks out more like a sore thumb now to not have the right information being shared in a clinical environment as well. Or
Exactly.
when you feel those tendencies kind of slide back into some of those old behaviors and changes
Yeah.
versus being able to slow down and really help paint the true picture for patients, but also for peers. And I'm sure you've heard me say this before as well. Doctors are still people. I love you. You're fantastic. And what you do is really important, but you're still people, which means you're still steeped in that same diet culture and misinformation noise as much as those clinical moments and that education moment. But you're seeing your peers and colleagues really engage with the kind of education and information that's coming forward.
I do see that. And then there's also patient advocates that are seen much more often now. I hope that when I see patients, they leave my clinic becoming patient advocates, colleagues I come in contact with. Um, it's as much as we would say things have shifted, it still requires a loud voice. And Obesity Canada is a loud voice for that. Our patient advocates are, and our physician partners are as well.
It takes a loud voice and that collective voice and on repeat. We know how many, if anybody has children, you know how many times you have to say a thing before it actually gets heard as well. So we're all just people along the way as well. So I love what you said there. And I know Ian's probably doing a little happy dance in the background as well, because we are really big proponents of being that informed patient or that patient advocate. And we know that being able to advocate for ourselves is really, really important in this moment. So we've put a lot of focus on making sure that we're sharing those clinical practice guidelines top down to the healthcare professionals, but Ian and I are really focused as well on doing bottom up and making sure that patients have a version of it that makes sense to them and that they can feel empowered to come into the room and talk in a way that is going to be effective and quick and informed, to gain trust between themselves and that caregiver that they're
I love
seeing.
that. I love that. That would be great.
And you're seeing an uptick in that?
I am. Yeah. I mean,
Yay.
the patients that come in to see me are either already informed or can't wait to be informed. Yeah. About
Mm, that's exciting.
resources.
Yeah, that's so great. That I feel like the narrative is changing, sometimes not exactly the way that we want, but all for the right reasons. And for all of those positive changes and awareness, there's still a ton of frustration that persists. Um, we, again, that noise of popular culture, but there have been a lot of instances of medication shortages as well. And that access to coverage continues to kind of be a lot for people. It can be almost too much for a patient to kind of navigate on their own, even if they are that informed and aware patient. How are
Yeah.
you helping patients and guiding those kinds of moments? Because it can feel like we're trying to boil the ocean, or like for me to get access to care is going to require the entire system of Canada to change or something like that. But I know that there's somewhere in the middle. How are you meeting that moment?
It is difficult because uh, even though obesity is a chronic disease, we hear more and more healthcare professionals say that. We hear some of our governing bodies even start to say that. It's still not considered the priority. It's still not considered acknowledged as important as a chronic disease as, let's say, diabetes might be or hypertension may be. So anytime that there's this overlap, it seems like obesity takes this back stage to it. Oh, this is not as important. And the way I manage that in a room with my patients is to reframe that, because even though there may be this notion that one chronic disease is more important than another chronic disease, that the evidence does not support it. And to sit there and reframe that, and to
Mm,
understand that my patients, whether or not they have one chronic disease or a complication of that chronic disease, is just as deserving for appropriate management as anybody else, as any other patient with any other chronic disease. So understanding that they are deserving of that, and they can hold their head up high with that.
mm. That is a really big part of it. And it's also a really fair point to say that, there are going to be complexities within this. And while we might arrive at your door wanting to deal with my obesity first, I imagine you have some conversations where you have to kind of challenge the order of events or help people reframe what their journey might look like. Is that something that you've experienced, and how do you kind of approach that moment?
Definitely. Yes, obesity is a neurobiological disease. Yes, there is chronicity to it. It has its own pathophysiology. But yes, there are influences and sometimes even root causes. So outside of that genetic, that innate neurobiology, there are other things that contribute, such as mental health um, disorders, such as disordered eating, hormonal abnormalities. These things can sometimes contribute so significantly that sometimes we need to deal with those first, and that may in and of itself have this overlap benefit that we would be looking for. So yeah, it's not just a straight, this is what we're dealing with and this is how we go. No, we kind of have to look at the whole picture and try to figure out what the best path forward would be for that individual that's sitting there in front of us.
Individualized care? What?
Oh,
What a time to be alive, right? I think Ian's going to hop in and join us as well and let us know if there's questions bumping or might join in and take us in
Yeah,
some other direction.
yeah. There's a couple of points that I wrote down here, but I think there was a few things that I wanted to touch on. There was a question that asked about the causes of obesity, whether it was genetic or lifestyle, and I think you did touch on a lot of that as you were talking so far. But yesterday I gave a presentation at a different conference, and I utilized for people that are in the know, that use the obesity systems map to kind of show the complexity of obesity. And it is, if you aren't aware of it, I can maybe see if I can dig up the link and share it in the chat. But it's a really complex diagram that shows all the intersecting factors that are influencing obesity or that are known to influence obesity. And there's hundreds of them, and they all kind of intersect with each other and connect. And so it
Almost
is not,
330 pathways, actually.
yeah, so 330 pathways. And so you can't say it's genetic or that it's lifestyle or that it's this. Like, it is very complex and it's going to be different for everyone. So I guess for you as a doctor, how do you have that conversation with someone? Like, how do you teach someone about that it's that complex?
I think just by exactly going through all of the different, not all, as many as I can say, or that we
Yeah.
can understand even yet, um, things that could influence. So when we do talk about the science behind weight, I go through some of the influencing factors that are underlying, and it's not for everybody. Not everyone has every single issue all the time. But there can be patients that have one or two. Um, Genetics is a strong factor, unfortunately. It is one of the strongest factors. But outside of that, work, stress, they change hormones and cortisol levels all the time. Um, Disordered eating patterns post trauma. Trauma could be physical or emotional. Pregnancy is a physical trauma to the body. Things change, hormones change. If the thyroid can change, why can't other hormones in the system change with things
Mm.
like physiological pregnancy? There are so many things that we know, but so many more that we still don't know in terms of pathways of what can turn that switch, if we can call it
Yeah. Yeah.
But genetics
Right.
is such a big part of it as well. And again, kind of relieving some of that burden that we might feel as patients as well. I know for me, I absolutely can look at my family tree and I can look at this picture of my grandmother that, like, from the back, it could have been me in that photo. And, she worked in a laundry on her feet all day long in really rural Alberta. She was not sitting eating bonbons. So, how do I not see that and understand that there's a genetic component to this that's really a lot bigger than me and that was probably put in motion even generations before my grandmother? But we don't
definitely.
see that, right? We lose sight of that because of all of that noise and that detachment from self that we're kind of told with diet culture.
and
It's big.
and just causation and fault, we take that on ourselves. We think that we are responsible for everything.
Yeah.
I was
I
responsible for all of my
definitely
issues.
I definitely feel that. I mean, as I was going through as I was a registered kinesiologist, exercise physiologist, and I knew more about the lifestyle side of this equation than most people did, and yet here I was still struggling mightily with it. And I took all that on. The whole brunt of it was, this was my fault. How can I even stand in front of people at a conference and talk about my research in obesity when I look the way I look? And I really struggled with that for a long time, and it took a while to kind of wrap my head around this, that it isn't entirely my fault. And I think when I have this conversation with people, I try to point out, like, I'm not trying to say that lifestyle factors aren't important, like the nutrition and the exercise, the activity. Those things are vitally important to health and well-being. We want everyone to move their body as much as they can. We want people to be active. We want people to eat as healthy as they happily can do so. But I want people to recognize that that is not going to be the solution in and of itself for a chronic disease. It's, if you look at that complexity of that map I was mentioning, you know, the diet and exercise piece is just a small piece of that. You can't solve a complex problem with such simplified solutions. So we just need to kind of shift how we're thinking about it.
I remember the first time I saw that same pathways map, and that's the spaghetti looking map, right? Where it's like there's a little orange dot in the middle. And that was genuinely my first experience, one of my first experiences with Obesity Canada. And Dr. Arya Sharma, who was the scientific director at the time, was speaking to it and seeing that little orange dot and going, that's me. And I'm meant to, like, understand all of these things going around it, or I think I can overcome all of those things just by doing another hour on the treadmill. Really? It's hard, but you really have to challenge yourself and break it down to that smallest component. I also had a moment the other week where I realized I hadn't weighed myself in quite some time, and flashed back to even, like 3 or 4 years ago, where I probably would have hopped on the scale 3 times a day easily. And what saying to myself now, what did I think I was looking for? What did I think I was going to see? And what did that really represent? So maybe how do you define success? Help your patients reframe success rather as well in these moments, because this is really
Yeah,
big.
it takes time. It does, to have that conversation, because um, when patients do come in, they come in with what they've been told is what they should way or what they should look like. And sometimes it feels like it's coming from ourselves, but it is coming from influences that are external. And I love the way Tara described how she measures her success, and that's really how I try to reframe it: is, are we healthy metabolically? Are we healthy
Mm.
mechanically? Can we move? Can we do the things that we want to do? Can we get up off the couch and go grab something from the other side of the room? Can we run that marathon? What do you want to do? And are we healthy mental health wise? And if all of those things, three things, are really great for you, then what are we looking for? Why is the number
Mm.
so important? And if the number is important, let's talk about why. What happened at that number? Um, oh, I felt really healthy. I remember I was able to get on the treadmill for an hour, and I felt really healthy after that. I could move better. I could lift this much. I felt nice, going out, and comfortable and not bloated, or whatever the situation was around that number. But then my question would be, is, if we felt all of those things and it wasn't that number, it was 10 higher or 20 higher or 30 higher, would that still be okay?
Mm.
And that starts to get us thinking as to, is the number really that important, or is it everything else?
Mm. And how what we attach to all of that everything else as well. It's big.
Very big. I There was another point that came up as you both were talking a little bit earlier, and it kind of surrounded the guidelines and the shifting of the narrative in the for health professionals and understanding of obesity as a chronic disease. And you had mentioned something. You said prior to hearing about this, you had no idea. So unless someone brought it to you, you wouldn't have known, type thing, or it might not have come up. I wanted to point out, like when we developed the clinical practice guidelines, we knew that that's kind of how things typically go. It's a top-down approach where the experts come up with these guidelines, they review all the evidence, they come up with guidelines, it goes out, and then it goes down through the professional kind of side of things from the top down. With these guidelines, we wanted there to be a mechanism for patients to become informed so that they could take this to their doctors, because it takes a long time for that top-down approach to get to your everyday regular family doctor practicing in their clinic. They might not hear about these for a long time. There's still, we're 4 years out, and there's still people who don't know that these guidelines exist. So we wanted there to be that mechanism where they could take this and have that conversation with their doctors and make them aware that there are guidelines out there and stuff like that. So in the chat, I did share a link to one of our resources. It was an infographic that was came out with the guidelines, and it was, I want to talk about obesity. And we thought about it as just a something that you could take to your doctor and spark that conversation. And it just says, like, obesity is a chronic disease. There's evidence-based treatments available. Here's a link to the guidelines. And so, I've talked to people who've utilized that, and they've had really productive discussions with their doctors. But for the people that might not know or might not have that, or for the doctors that don't know, how can we as patients approach that conversation when we're trying to bring up something that the doctor's maybe not aware of or doesn't know much about because they weren't trained in that area?
Yeah. I mean, and it's common, right? It's not something that until very recently was part of the medical curriculum. this is new. All of the courses around obesity, all of the extra training that docs who are going back for CME, this is all new. So yeah, definitely, there's a huge subset of the population that may not have even heard of any of this. For patients, I would say don't mix this in with other health ailments. Like, if this is something that we want to talk about, make an appointment specifically for this. Because it's not, because your doc might not be aware of the chronicity of this disease, or have this this new information that has come out in the last decade. Have that conversation about it specifically, because other things will take over the visit if we add different things to it. Different things will feel more important for a physician's agenda. So make sure that there's nothing else to talk about, and have that conversation in that moment, and go in a little bit prepared, maybe with a story from a colleague or a friend, or with the guidelines that you were talking about, that map that you've put up, if there is resistance to this. And hopefully this is something that's going to end up being a really great conversation. This might be a learning opportunity for both patient and physician, and maybe this could turn into a really, really great management pathway for them. And if not, there is that opportunity to say, hey, you know what? I know this might not be something that, we can do here together. Is there somewhere that you could send me for that? Or do you have allied health care to help me with that? Or someone in your team that is aware of this that could help me with that? And kind of be able to navigate some of that yourself.
Awesome. Yeah. There was a question in the chat that kind of connects to this, and it said, what is being taught about obesity in medical and nursing schools? So, as you went through medical school, was there anything being taught about obesity?
No, we were being taught by everything that was in the media. That was, it's the same. Exercise more, eat less. That's really what we knew, because we didn't know much, and that's the only thing that was out there to grab. Once the science has come out and it's starting to be more robust, and we're looking at different pathways and different mechanisms where obesity lies, and also mechanisms and pathways of treatment, this is becoming a really exciting, robust field of science, and that's why now it's something that needs to be in the medical curriculum. It not only is in and of itself an important chronic disease to understand, but it's so important to understand why this particular chronic disease stems into many other chronic diseases.
Yeah. And it's something that, since the guidelines came out, Obesity Canada has been involved in a lot of medical education. So we have our own training that we provide to doctors and other allied health professionals. And so that's stuff that's been going on. But, we have medical schools and other allied health professional schools reaching out to us all the time, asking us for special lectures or series on obesity. So there are doctors who are being trained. There are people who are getting that information across to the next generation of health professionals. But it is, again, something that is a little bit of a slow process.
I would say that it will become unavoidable. There will come a time where there can't be a graduating class that does not understand obesity.
Yeah, absolutely. So, we've talked about the guidelines, and maybe one of the things, I think it's been mentioned, but the pillars of obesity management that we talk about from the guidelines. So we have our psychological interventions, the bariatric surgery, and the pharmacological interventions for obesity are the three kind of evidence-based treatments that we consider for obesity. And then those support the behavioral stuff, the nutrition and the activity and the exercise and those sorts of things. I guess to go back to kind of the title of this session, where we're talking about, like, if it's a disease, why can't I get help? This is something we hear about all the time. People go to their doctor and they talk about obesity as a disease. They get told that there's these three pillars that are available to them that are, evidence-based treatments, but they don't have access to any of them. So someone who doesn't have very good, supplemental coverage, getting cognitive behavioral therapy is expensive and not generally covered to the extent that we would need to have decent enough coverage or decent enough care on that. A lot of times the obesity medications they are classified as lifestyle medications and aren't in the formulary that other chronic disease medications are. So the coverage for them is non-existent. And then if we look at the bariatric surgery kind of arm there's lots of places where the wait list for bariatric surgery could be years. So we have these three great pillars of treatment that are evidence-based, but people can't access them. In your practice, do you come across that? And how do you help someone and keep kind of spirits up when they're running into barriers like that? Did we lose her?
It looks like she might be frozen. Oh, and she's gone. Well, let's talk about these pillars for a minute, because I know we have Dr. Macklin later today as well. And one of the things that I really heard him say as well, and you just said it, so we're kind of repeating where we were, but I want to bring it up again, is that, we have those big pillars, the therapy, the psychological interventions, the surgical interventions, and then the pharmacotherapy. But really, those are what enable and make that diet and exercise component even possible. And that's such an important flip in the narrative as well, that I know Taz would probably have a lot of things to say about. But that is a really interesting and important point, don't you think, Ian, that I think as patients we need to understand as well. It isn't that those two, the diet and exercise, are driving the bus per se. It's that they're more enabled when you have that proper care and treatment below it.
Yeah. And I mean, I can talk about my experience, like with either any of those pillars, but let's say with the medications, for example. Since taking a medication, I can tell you that my ability to have control over, my behaviors like nutrition and activity and stuff like that is significantly improved. And so it's not that I don't do those things, it's that I have support for that now that makes it a lot easier, a lot better for me to do.
It makes all the difference in the world. Sounds like we might have Taz back, and she might be joining us in one. There she is! Yay!
I have no idea.
This is life. This is life. It's okay. This is totally okay, my friend. It's not because Ian asked you a really hard question. I know that's not why you just bounced, right? But
did you hear that question though?
I didn't actually hear the last line, so I know we were talking about the pillars and access to potentially the psychological pillar. In term, was that what it was?
So I was just saying that we have, like we've been taught, and we know that we have these three pillars: the psychological, the bariatric surgery, and the pharmacotherapy. Those three pillars of evidence-based treatment, but we're oftentimes running into barriers as patients with there being limited access for all three pillars, right? There's some people who don't have access to any of those pillars. For you as a health professional, is there anything, have you come across that? Or is it something that you would be able to talk someone through if they didn't have access to any of those pillars? Like, how can we still make it successful management when we don't have those things?
Yeah, I mean, I feel like I can only talk to the environment that I work in terms of the Alberta landscape. What's really exciting here is that we do have primary care networks that do provide some behavioral or psychological assistance to our patients. It's not grand, but what's really exciting to me is that this is something that's being it's an uptake of these kinds of networks all throughout the country, and that's what I have been hearing. And not only do we have these networks, the allied health in these networks are actually being mandated to take these courses from Obesity Canada. At least the primary care networks that we have in Alberta have at least one or two nurses or dietitians or other allied health that have CBEs, and potentially even further behavioral health consultation. Behavioral health consultation training. So I feel that it is shifting. Unfortunately, this is the complaint for most psychological intervention in many, many chronic diseases. I'm actually a little surprised that the interest in obesity behavioral change is actually higher than other chronic diseases that I've noticed recently, because we have this opportunity to learn. They have this space where they can go and say, I want to know more about this. I want to know how to help my patients, and have that education from Obesity Canada, which is really great.
Nice.
I know for me, one of the things that took my brain a minute to really catch up to is that sensibility, just because you were talking about behavioral change as well, that weight is not a behavior. And that's a really simple sentence to say. It's a harder one to kind of understand and truly embrace. So maybe can we talk about that? Weight is not a behavior. Do you bring that up
Yeah.
in your practice, or how do you
All the time.
nuance that and talk about that with patients?
And I feel like it becomes an organic conversation, because most patients that come in specifically for weight management don't tend to come in saying, I've never tried anything before and I've never done anything before. Most of them come in saying, I've tried multiple different things. I've looked up multiple different websites. I've engaged in many different physical activities. I'm doing everything I can possibly do, and I've done it multiple times over, and it doesn't change. Okay, I believe you. And it doesn't
Ugh.
change because that's not how it works. Numbers don't change because we will them to change. We can only change what we do and how we feel when we do those things. But that doesn't necessarily need to be reflected in a number. When we exercise, does our blood pressure improve? Maybe, hopefully. How much it improves, I don't know. I can't tell you what number that's going to be. I can't even tell you what happens with the medication. But we can do what we have available to improve your life and the way you live and the way you feel. But I can't guarantee a number. You can't guarantee a number. Nobody can.
I love what you said in those three sentences. I believe you. That's really, really powerful. And I want everybody to understand that for a moment. Oh, I got bubbles on my screen. That's really powerful and really important. Why are those? Okay, anyway. But it is really important and really powerful. I know for me, some of those first experiences with a healthcare practitioner who truly got it and was telling me to take off some of those biometric things, I felt heard. I felt believed. Whereas before, I might have, my weight may have come up in conversations and I would say I was doing all of these things, or here's my food journal for literally the last 5 years of my life. It wasn't that my behaviors were out of order or needed to change. My weight is not a behavior. I want people to hear that one really, really loudly, because it's a really important one. And we can only control what we can control. And our weight really isn't totally within our control at all. I believe you. It's huge, people. It's huge.
We did have a question that just popped up, and it was, what is the efficacy of mental health intervention in obesity treatment? And I think I'll let you touch in on this, but I imagine that would be on a case by case basis. It's not going to be the right treatment for everyone, but for the people that require that, it could be very effective.
I'm going to say right off the bat, measuring of that as to how effective mental health intervention is ongoing. We're trying to look at best practices into how to measure that effective change. Now, when it comes to who finds benefit, everyone is so different. That umbrella of behavioral or psychological intervention, yes, may involve some behaviors around nutrition, behaviors around sleep, behaviors around stress, emotional regulation and dysregulation, and its relationship to our activities or our nutrition, mental health, but not everyone has the same issues. Not everyone has the same underlying causes. So if we do have patients that have particular underlying root causes, then we do move forward and tackle those root causes. One, yes, in the intent to help with obesity management, but also in the intent to help that root cause. And not everyone is similar. So it is a little bit hard to measure those things, but even so, we're looking into how to find some really great best practices in measuring that right now.
I don't think we have any more questions in the chat. I can see. Did we lose Lisa? It looks like she might be frozen.
Oh no, I'm here. I'm writing. I'm writing notes like a nerd. Sorry, everybody. I am here. No, I genuinely am just writing down all of these notes because I think it is so important to really make that empowered and informed patient understand all of these different nuances and complexities, because it's not like we're going to be able to rock up on day one and say like, all right, I'm ready to tackle this. And you're going to be able to have a magic wand and give me an answer even day one, maybe not even a plan of attack on day one. These are going to take more than one conversation to kind of get all of the right wheels in motion. And that's a big part of it, is what we need to get in motion for each person is going to be individualized and be a little bit different. And we need to be grateful that we have care practitioners like you that want to slow down and understand the background as well, and not just the person right in front of me. You understand that there's a lot of layers to that, and we all have a lot of layers. So it's really challenging. And I imagine as a healthcare practitioner, making that space, genuinely, literally making the time, feels like a challenge on your part. How do you help your patients understand kind of what the runway or what the roadmap is going to look like, and that this is going to take a minute to unpickle?
I can walk you through one of the first visits that we have. And usually the first visit for me is to know who my patients are, try to get to know them, try to get to understand what their journey has been. Are they here because they really truly would like to be here? Are they here because they feel like they need to be here? And are they expecting a true comprehensive visit today, or are they just expecting to hear what they've always heard every single time they go in for something related to weight? So it's a visit that's a lot of information gathering for me, and also we spend a lot of time in information delivery as to the science behind weight, as to how we need to treat this individually, like the chronic disease, and individually for that patient with multimodal techniques. It's not a one thing that's going to solve all of our problems. And to figure out what our management plan would be, we need to know a little bit more about them metabolically, a little bit more about them in terms of their mental health. And I need them to take some of that information back and sit with it as well, because it takes a while sometimes to get rid of those biases from ourselves. And it takes a while to like, did she just tell me that this has nothing to do with how hard I work? And did she just say that there's something else happening? There's hormones here that I can't control. And that's a little bit of, a little bit of letting go of control and understanding that this is something that we need to work together to kind of figure out how we solve or manage this issue. And then from that visit on, they understand that there's going to be conversations around nutrition. There's going to be conversations around behavior. And we'll tackle the different things that we need to tackle for that particular patient. And there may be possible pharmacotherapy that we use. And that's not to say I'm going to be holding pharmacotherapy hostage to any nutritional and behavioral change. Why would I do that? If I wouldn't do that in someone that comes in with a blood pressure of 180/90, I'm not going to tell them go home and cut the salt and exercise. And if everything's okay, great. If not, then I'll treat you. No. We're gonna do this in a multimodal way and do what we need to do.
That's really big too, because it does often feel, or I think we've heard a fair bit in the community as well, that it does feel like, okay, go and give me 5 pounds
Yeah.
and then we'll
Yeah.
play. And we've heard that in the community from people who need other aspects of care like knee replacements or other joint replacements. And they're like, okay, if you lose 30 pounds, then we can talk about this. But losing 30 pounds isn't, again, that isn't a behavior change. Weight is not a behavior. So
Yeah.
I think that understanding, and I love the way that you talk about individualized care and that multimodal care. I think people need to understand that sooner than later. And we also need to keep reminding ourselves this is going to be kind of a topic for the rest of our lives. As a lady who is broaching 50 very quickly, I feel really good in my body today, but I also recognize that there is a tsunami headed my way of hormones that we're going to have to figure out all over again. And that's partly because I'm a woman and I'm going to be going towards menopause, but also because I am taking these medications that are for hormonal reactions. And that's going to be another conversation and a potential another challenge on the horizon.
Yeah.
So we need to get comfortable with these conversations because they're going to be for the rest of our lives. And there's going to continue to be new information and potentially other options for us to
Yeah.
go in together as well. So it's really about creating that partnership, right? Because this is hopefully going to be for a while that we're going to be in care together.
Yeah. Okay, I'm going to speak to that surgical thing for a second.
Hmm. Please.
In terms of, I mean, where the evidence is around how much particular loss we need prior to surgery, I have my own thoughts on that. But yeah, there are situations in where patients may need to have some acute or fast or rapid weight reduction to get a surgery or something that could be life-saving, a fertility treatment, a knee replacement. I don't consider that chronic weight management. I
Mm.
don't. I consider that acute weight management. I consider that a means to an end. And that is something that can be done, but that is temporary. That is not an expectation that's going to last. We need to do this to have this done. Great. Then after that, we need to talk about chronic weight management. I think there needs to be um, a separation between those two kinds of weight management.
That's really, and that's also super healthy to be able to approach it that way because, again, like especially in those fertility moments or those joint replacements, there is time sensitivity often around them. And I appreciate that we don't want to confuse those two
No.
moments and we can maybe do things to help get you into that moment that you're looking for, but that isn't also the end of the story. I also know there's a lot of there continues to be a bit of stigma around the medication options. And we know that there's challenges in coverage and we know there's challenges in even just supply and demand. But there's also challenges. And I know I, again, have had this moment where I'm like, maybe it's time to wean off, or maybe I don't need that anymore. And I think
Yeah.
that's going to be an ongoing challenge and conversation because, again, pop culture is making it feel like you can do this for 5 pounds or 10 pounds and then it's going to be great. When in reality, for many people and those of us living with obesity, for me, those medications are like my glasses. I take my glasses off at the end of the night. I don't expect my eyes to be better or that I don't need them the next day. Why do you think we have that perception when it comes to these weight loss medications? And how are you kind of navigating those conversations, or have you had to?
Well, why do we still have those perceptions is because we are just accosted with the weight bias and stigma still. So there's still a long ways to go. So after we've had those initial conversations, um, do you guys still with me?
Yep, we're good.
Yeah. Okay. After we've had those initial conversations, um, time can unfortunately seep through those barriers we've built up and the weight bias and the weight stigma
Mm.
can seep back in and say, hey, you know what, I'm doing really well. I should be able to do this myself now, because I've had these really great learned behaviors. I've really changed the way my nutritional intake is. I'm enjoying what I eat. I'm not restricting. I feel satisfied. And I like where I am. So, I don't need this anymore. And I don't. I think it's because this stigma still exists and we start believing that it was our fault to begin with again. So having those conversations again, it is going to be important, but also understanding that chronic disease improves and worsens, right?
Mm.
And we can see that in every chronic disease. So if somebody has hypertension and their blood pressure has improved significantly, if they do discontinue that medication, yes, our body doesn't get an education from these medications, so it won't remember that, oh, this is how we were supposed to work. But what could happen potentially is we could adjust dosing to see how our body responds. So it's not like, oh, we're going to start on this and we're going to do this forever at this dose for the rest of our lives. There's always conversation. Chronic disease changes, waxes and wanes, and we change, add, or reduce medications for every chronic disease as we go through our lifetimes. So there may be value in talking about, hey, maybe I don't need as much right now. And we can talk about down tapering. Or, hey, I feel a little bit like I did way before I had some weight management intervention. Maybe we can up taper. Or maybe this isn't working anymore, and maybe we need to add a second medication. So it's going to be a conversation like it would be around any other chronic disease.
What a time to be alive, though, because we're not used to that sensibility often. It's so we're so used to having that blame put back on us as patients. It's so exciting to think about this being our baseline and the way that everyone receives care and treatment. So maybe let's go there to kind of bring us home. And I'd love to hear from you that, this is an exciting time for the world of obesity and obesity care. What excites you most about this moment that we're in and kind of what the future might look like, or we could help make it look like?
I would love for this to be treated like any other chronic disease. When someone walks into the clinic and they talk about feeling low, feeling sad, not finding the joy in their lives, we're really quick to say, hey, I've got this scale for you to fill out. Can you fill this out for me? Hey, you know what? It looks like you may be suffering from some depression. I know that you need to go to see this psychologist. I'm going to send you to this allied health professional. We're going to look into these lab works. And you know what? Maybe we'll consider some medication. We know exactly what to do at exactly the right moment because we've learned this, we believe in it, and we understand that there's a science behind it. I want every doc and every allied health professional that comes out of their programs to understand that like that.
I believe that is possible. I truly
I do
do.
too.
I think that we can get there. I think that there's a road ahead of us, but we have all the right tools and the road exists. So I think
Yeah.
that we can absolutely take ourselves and the rest of Canada along with us for sure. Amazing. Ian, do we have anything left from the community at large out there? Does everybody just wish they had Taz as their doctor? Because I know I do. But sorry, Dr. Sedgwani.
There is a question that there is a question about medications. This discussion about medications, and I don't know if it'll take us down a rabbit hole, but maybe we can address it quickly.
Sure.
Maybe it's something we address somewhere else, but it was talking about with all the different medications being prescribed for other things that could potentially cause weight. Is there known ones to avoid as far as weight gain or things that might impact obesity, or how do you manage those situations where you got medications and interact the other way?
This is where the Canadian Obesity Guidelines has a really great chart of medications that are obesogenic, that do Wayne, and kind of take a look at those lists and make sure that we're looking at those lists, or maybe talking to our docs about, hey, this one kind of causes some weight gain. Is there an option that I can take that isn't this medication? Because obesity is a concern of mine.
Yeah, so having the link to those guidelines on the Obesity Canada website could be really helpful there. And having those conversations again is also important. Like sometimes, there might not be another option, or maybe that medication that you're taking takes priority under certain circumstances. But it's good to be aware and to know for sure.
Yeah. And I think the key is also to have that kind of partnership where you can put it on the table and say, this is my concern. And then have the right conversation with the physician about, like, understand, hear your concern, and this is how we're going to monitor it together, and how we're going to check in with each other along the way as well. Because again, just feeling heard and hearing those words, I believe you, is going to make such a big difference. It's huge.
Yeah.
Well, that is so fantastic. I think we're close enough to time that we can call it. I really want to thank you, Dr. Sajwani. You are such an inspiration and an amazing example of compassion and care, and what the future of obesity care should look like. Appreciate your time today. Thank you. And we appreciate sincerely everything you do day in and day out to make a difference, and how you're helping to spread the word. We all need someone like you in our corner. So thank you. I look forward to seeing you again next. And with that, we are ready to move to our first break of the day.